talk about is basically designed to improve the lipophilicity and bioavailability of sirolimus, and it ensures better coating of sirolimus on the balloon. It is basically mixed with phospholipid drug carrier, which has 2 lipophilic tails and 1 hydrophilic head. It is encapsulated in this phospholipid with nanolute technology and then spray coated on the balloon, initially with low pressure inflation and after folding also. And this ensures kind of much better release of the drug with better tissue retention. Facilitates better adhesion on the balloon surface, circumferential coating, effective drug transfer, and better tissue bioavailability. And this has been tested in various labs, especially Dr. Renu Virmani's lab. The pharmacokinetic study of drug delivery also shows that the tissue concentration of sirolimus with this technology persists for up to day 14, and in some cases it is seen beyond day 30 also. Potential for drug-coated balloon in complex cases is, of course, there are no additional metal layers, reduced need for prolonged dual antiplatelet therapy, repeatability of the procedure, reduced vascular inflammatory response because of polymer-free design. And these are the basic premises because of which we should think of using drug-coated balloons in our complex PCIs as well. Nanolute registry was one of the first registries to use sirolimus-coated balloons in all comers. It was prospective, multi-center clinical registry across India, enrolling real-world all-comers, and primary endpoint was a MACE, which was a composite of cardiac death, target vessel myocardial infarction, and target lesion or vessel revascularization. Procedural success was defined as technical and angiographic success in the absence of MACE at hospital discharge. Secondary endpoints was same MACE at 1 year. The baseline characteristics of these 450 patient registry was pretty similar or pretty representative of patients found in our country. Large number were diabetic and hypertensive. There were good number who were having acute coronary syndrome. I will just shift to the clinical outcomes. Up to 3 years, it showed reasonably good clinical outcome across all the strata of the patients, and that included in-stent restenosis, included diffuse disease and small vessels. Some of them bifurcations also. If you look at the ISR, especially DES ISR and small vessel subgroups, again the MACE rates were quite acceptable in all these subgroups as well. So complex PCI, at least in real world, the data with sirolimus-coated balloon is looking quite acceptable. As I said, potential for these in complex PCI is there, and potential, looking at those benefits, potential clinical situations for DCB, in-stent restenosis where DES ISR and BMS ISR, the data is plenty, and nowadays guidelines also tell us that in bare metal stent ISR, DCB should be the first choice. It may be not in DES ISR, but still it is debatable. Small vessel disease where stents can't be placed, diffuse disease where you don't want to stent the entire lesion, bifurcations where you want to treat the side branch without stenting it, or sometimes even the entire bifurcation when it is small vessel. Sometimes in combination with DES in long lesions. Not only that, as Dr. Colombo came up with an idea of using DCB and DES together in those high-risk patients who have very high rates of wrist stenosis. Now, data for all this is not easily available and it is not very convincing. So these are potential clinical situations where we could use drug-coated balloons and for which there is a logical sense. And of course, the last but not the least, very important, patients with high bleeding risk, where you could use drug-coated balloon because it has been shown that DAPT requirement is not more than 1 month. And most of our patients, we use DAPT only for 3 months if they have been given only drug-coated balloon. I'll just show you a couple of cases for want of time. This was a 47-year-old male, came with acute coronary syndrome, in fact acute inferior wall MI, mid-RCA occlusion. His angioplasty was done and he was counseled for CABG because he had triple vessel disease. He had diffuse disease in circumflex, he had mid-LAD lesion with diffuse distal LAD lesion. And he had, after opening the RCA, he had diffuse distal RCA disease as well. But after stabilization, he refused bypass. The mid-RCA lesion, which was opened with a plain balloon, looked quite okay on angiography, but IVUS showed significant disease there. And there was a bifurcation lesion there. IVUS was done, cutting balloon was used to get a good lumen. And a larger cutting balloon was used for the mid-RCA lesion also. For the distal disease, magic touch, sirolimus coated balloon was used, 2.25 by 40. And for the distal RCA, 2.7 by 40. For the mid RCA, cutting balloon followed by sirolimus coated balloon. And final result was quite satisfactory, and this was confirmed with IVUS. So this is, as Dr. Colombo said, images don't constitute an evidence, but this is just goes to show that when you persist diligently and do a meticulous angioplasty, you can get good results with drug-coated balloons also. Previously, we used to, in bare metal stent era, we used to leave a good result, which we used to call SLR, stent-like result. When you got a good result with angioplasty, you would leave it. But then in DES era, we understood that even SLR is not comparable to the drug-eluting stent result. But now, with drug-coated balloon, that may change. Circumflex, again, diffusely disease was tackled with drug-coated balloon. .5 by 40. And final result was quite good. LAD, mid-LAD we did stent, and distal LAD, again DCB. And this was the final result. I'll skip the other cases, but this was an interesting case in that this was a 73-year-old lady who had 2 drug-eluting stents in RCA implanted at the time of ACS, and she came back with wrist stenosis at the junction of 2 stents, and about 10 millimeter away from that, IVUS confirmed that there was slightly inadequate expansion of the stent at that juncture, and we used DCBs. after adequately expanding the stent. That is very important. This was a post-CABG case. Again, now I will move fast. Where after rotablating, we used a combination of DES and DCB in circumflex. This was another interesting case where there was a mid-LAD bifurcation lesion and the patient did not want a stent. So this was the lesion. Patient did not want stent, and then we decided to give him option of drug-coated balloon. We did pre-dilatation with a cutting balloon, 2.75 by 10 millimeter at 12 atmosphere. It recoiled even after cutting balloon. So we gave for high pressure dilatation. Still there was a recoil. At 20 atmosphere, still there was recoil. Then we took a larger cutting balloon. And then followed by high pressure dilatation with ANSI balloon. And then finally, once we got adequate lumen, drug-coated balloon, and we did a final kissing with drug-coated balloon. So these are just case examples. Doesn't mean that we should be doing all this unless we get more and more evidence which is accumulated. What do guidelines say? Drug-coated balloons are recommended for the treatment of ISR, BMS or DES. That recommendation has been there since 2018. It's class 1A. And Italian Society also recommends DCB for BMS restenosis management. For DES, there is evidence that repeat revascularization is less with repeat DES. And that's why we are not using DCB as a first choice in all DES ISR. But of course, one can make a case for them also. Use of DCB for small coronary vessels, again class 2A indication, and use of DCB in the treatment of bifurcation lesions with provisional bare metal stenting, again class 2A recommendation. The German group, which is even more aggressive in use of drug-coated balloons, use of DCB for ISR, small coronary and treatment of bifurcation lesions, all they've put it in recommended group. Similar goes from China. ditto. It's very important to understand that the pre-dilatation is very important. So optimal lesion preparation is very important if you want to use DCB. So in general, I would say that today, if it is first intervention, excellent result with pre-dilatation, I may entertain an idea of using DCB in some patients, especially in those patients where I want to avoid multiple layers of stents or multiple stents, or those patients who have very high bleeding risk. This is where probably right now the DCBs stand, but we are accumulating more and more data, and more data is required. There is a trial called Ginger study which is going on. There is Eastbourne registry is already completed for native coronary lesions, and there are at least 3 more randomized trials planned or underway for use of DCB in native coronary vessels in de novo coronary lesions. So in coming years, we will know much more about use of DCB in complex PCI. Thank you.